the session is being recorded, and a copy of this will be available on the website probably towards the latter part of next week. So, and Cumwood, would you mind just posting the web address in the chat? Super. So Cumwood Cantilal is working in the background, so she will be posting various resources in the chat throughout this session. And what she'll also be doing is monitoring questions in the chat. So it is as interactive as we can kind of be when we're doing this in this sort of online forum. So please, throughout the session, as questions, as comments come to your mind, post them in the chat. As I said, Cumwood will be monitoring those, and she'll draw those together so that we can pick them up towards the latter part of this session in the curated conversation. So whilst the session is on behavioural science, what I would like to do is very quickly hand over to Professor Goodman to give you an overview of what the ARC is. So I'll hand over to you, Claire.
Thanks very much. So I'm Claire Goodman and part of the Applied Research Collaboration East of England. And these virtual organisations funded by the National Institute of Health Research, there are 15 across England. And our goal is to facilitate the implementation of best evidence and research that supports implementation of best evidence. And these webinars are the second ones that we're doing. We started with care homes during a time of COVID. And what the advantage of the ARC is that it is a partnership between academics from 4 universities, Cambridge, Hertfordshire, UEA and Essex. And we work together, and whilst we may be doing our research regionally, it's very much of national and international relevance, and we're delighted that there are so many people, not only from UK but also further afield, because we are all facing very similar issues in the developed world in our health and social care. If you don't receive the ARC East of England newsletter, do sign up for it. We will be posting news of future events, and this one is very much speaking to how we support people with multiple long-term conditions. So the theme I lead is about aging, but also about people who are living with long-term conditions. And medication is often and obviously a key issue. So I'm going to hand back now to Debbie to allow the presentations. And we have deliberately given plenty of time for discussion. And previously we've discovered that for many, that has been as rich an experience as hearing about the research. Thank you.
Super, thanks, Claire. So as Claire said, this is the first of a series of 2 webinars. This one's on deprescribing, and then early next year we will have a session on medication adherence and how we might use behavioural science to address that challenge. So the plan for the next hour is that I will give a very quick introduction to what we mean by behavioural science and deprescribing, and then talk through an example of a completed study, an NIHR-funded study to address opioid deprescribing. And then I'll hand over to talk about to Dr. Scott, who will introduce an ongoing NIHR programme of research about deprescribing. And then, as Claire said, we've allowed for lots of time at the end for discussion. So please, throughout the talks, post your comments, post your questions in the chat, and Cumwood will synthesize those for us at the end. So I thought it might be useful to give you a quick kind of outline of our background. So both Sean and I, our research expertise is around behavioural science, and we're both pharmacists. Sean's background is in hospital pharmacy, mine is in primary care, and so that's why historically the behavioural science research methods we've tended to apply to medicine's optimisation challenges. So my interest in behavioural science really comes from my practice as a pharmacist. So I found myself early in my career spending an awful lot of time talking to patients about how to take their medicines, why it was important they take their medicines. And then I thought to myself, well, actually, there's a lot of things where I know how I should do it, and I know that it's important I should do it, but it doesn't make me do it. So there's a whole load of other stuff going on that dictates our behaviour. And we know that. So, for example, with smoking, most smokers, I'm sure, are very aware that it is not good for their health, and yet they continue to do that. So knowledge alone does not change behaviour, and yet we still see a lot of interventions within the healthcare setting that are very focused on providing people with knowledge in the hope that that will then change behaviour. So the same goes also for practitioners. Just giving them the facts, telling them what they need to do, does not make them necessarily do that behaviour. So we see a gap between what the evidence says that they should be doing and the actual practice, what we observe. And of course, that's not good then for patient care. So behavioural science, what it's doing is looking to unpack this black box. What is it that is going on between the knowledge, the evidence of what we should do, and then the practice of what we actually observe? So what we're looking to do is diagnose those key factors that are influencing whether a person or a group of people undertake the desired behaviour. And so once we've identified those key factors, we'll then be looking to address them. So if there are barriers, we would introduce intervention components that will help remove that barrier. And if there are enablers, if there are things that are going to facilitate the practitioner, then we'll be looking, or the patient, we'll be looking to then introduce those as intervention components. And that really is what behavioural science is, prioritising what are the main factors that are influencing someone's behaviour and addressing them. So in the run-up to this session, we asked you for your motivation for joining the session, because as Claire said, what we really want with these sessions is not for us to just talk at you, but for us to help you build a network, help you share ideas, and so that future projects can blossom from this. So we found that we have got participants from across the globe, and these were kind of the motivations for joining. So we have got some experts in the room, and so what we'll be looking to do, hopefully if you're willing, is to link those experts up with those that are looking to actually start using behavioural science to address medicine's optimisation challenges. And hopefully during the session we'll give you a flavour of what it looks like and really pique your interest, so that you can also start to work towards embedding that into future projects. So we talked about behavioural science, and now in terms of what we mean by deprescribing, which is what this session is about, deprescribing really is a part of that continuum of the process of prescribing. So we start with the diagnosis, and in response to that diagnosis, we prescribe a medicine. And at that point, it's because the prescriber, the patient together decide that on balance, the benefits of that medicine outweigh the risk of any harms. We will then monitor, having prescribed that medicine, and at some point, the benefits and harms, that balance may well shift. And that's the point at which we want to stop that medicine. And that is the behaviour that is currently not routinely happening when it needs to. So that's why we're seeing this area of deprescribing research really build, because we need prescribers and patients to work together to stop medicines when that balance shifts. So the first project that I would like to introduce, that is a completed project that was funded by the NIHR, was to develop an intervention to support prescribers to deprescribe opioids. And the background to the methodological approach that we used was that there's already a huge amount of research in this area. So we didn't want to reinvent the wheel, we wanted to learn from it. So the trials that are out there are largely focused on patient behaviour change, but we know that it's a partnership. It's not just the patient alone, so the prescriber also has a role to play. So we were looking to see whether these deprescribing trials would give us some learning about how to facilitate prescribers to engage with deprescribing. The other element that is of note is that none of these trials, whilst the trials may well have been very successful, none of them have been successfully implemented into the real world environment and had the same outcome, managed to exert exactly the same effects. And so that's why we also wanted to look at the real world examples, real world innovations that people had implemented to see what we could learn from them. And then the final factor that influenced the methodological option that we chose was that all of the interventions are highly complex. And so that means there will be some elements that were really working very effectively, but there may have been some that were redundant and therefore, you know, they're costly, and if they're not contributing anything, they shouldn't be there. There may also be some elements that are counterproductive. So that's why we wanted to unpick from these complex interventions what is actually working. The approach that we took was a realist approach. So what realist methods do is they build on existing research. It's a way of synthesizing existing data. So it looks at interventions to see if there are any factors that affect the outcomes that we observe. So anything that makes it more or less likely to get the desired outcome. So if we look at this example here, we've got someone implemented the same program, 2 different locations, but really different outcomes. And if we look at the different locations, it seems obvious that you may well get a different outcome. We've got one highly densely populated, highly urbanized, another that's rural, much more sparsely populated. So what we can see here is that the context within which that intervention is implemented is influencing the outcome that we observe. So that's one element that a realist review is looking to establish. What are the contexts that influence the outcomes? The other thing that we were looking at is understanding why things work. So here we have this example of someone throwing up a tennis ball in the air and it falls back down. So that's our outcome that we're observing. We also understand the mechanism. The mechanism is gravity. Now, because we understand the mechanism, we're now not tied to having to use exactly what they used in the trial setting. So if I didn't have a tennis ball, I could replace the tennis ball with an orange or an apple, and I throw it in the air and it still falls down. Because I understand the mechanism, I knew that would happen. One would never ordinarily think that a tennis ball could be replaced with an apple or an orange. But what this means is that things we find in a trial setting that are effective, we understand the mechanism, we can translate that into the real world setting by using different things that are available to us based on our resources, but may not be exactly faithful to the trial materials. So that's kind of an overview of a realist approach. The first step in a realist review is developing initial program theories. And this is basically hypotheses for how we think intervention components might work to give a certain outcome, why it is, the mechanism by which it's doing that, and any contexts that might influence that outcome. So here's an example of a hypothesis of a program theory that we developed. So we thought that prescribers are more likely to have more deprescribing discussions if we give them training, and we hypothesize that the training is not giving them knowledge and skills, it's boosting confidence. And what that means, if that were to be true, it means that it doesn't matter what training you give them. You could give really expensive, super duper training, or you could give much more economical training, and it would still boost confidence. So that's why understanding the mechanism is really important. And then we hypothesized that perhaps medical practices that had lots of patients prescribed high dose opioids would be encountering this much more often, and therefore would start to gain more confidence and therefore would be more likely to initiate deprescribing discussions, whilst those with a context of far fewer patients would therefore deal with it less often, therefore have less confidence, and therefore be less likely to initiate discussions. So that's an example of an initial program theory. But this talk is supposed to be about behavioural science, not about realist methods. So what was particularly novel about what we did is that the way that we developed those initial program theories. Ordinarily, often they would be developed through using the experiences of the team and through reading the literature. And so what happens is the program theories are driven by what we already know, by the literature, by our experiences. We used behaviour change theory. We could have picked one or two theories to guide the development of our initial program theories. There are huge amounts of theories out there. And so actually it's a bit of a gamble. You know, if we didn't pick the right combinations of theories, we could have missed some really key determinants of prescribers' deprescribing behaviour. So instead of picking any one or two theories, we picked the theoretical domains framework. And what this is that a group have mashed together all of these behaviour change theories, identified the commonalities, identified the differences, and what has fallen out is 14 domains that are key to unpicking why people do what they do, why they undertake a behaviour. The other beauty of the theoretical domains framework is that each of these 14 domains is linked to interventions to address the domain. So we didn't use that in our research, but Sean later on will talk about a project where we did. So here is the theoretical domains framework. So there are 14 domains. So this is basically saying that all of these need to be in place for someone to undertake the behaviour you want. So they need to have the knowledge to do it. They need to know how to deprescribe. They need to have the skills to initiate those deprescribing consultations. They need to feel that it aligns with their social professional role and identity. They need to believe in their ability to be able to deprescribe. They need to be optimistic that they'll be able to do it, that good things will happen, the consequences if they deprescribe, and so on. So that's the theoretical domains framework. And what we did is we developed initial program theories for each of these domains, and for some of them multiple. And there's no way, without the theoretical domains framework, I can guarantee we would never have generated all of these program theories spanning these potential determinants. So what I'll do now is just give you an example of what these initial program theories look like, just for these first three domains. So for the domain of knowledge, we developed a program theory about incorporating guidelines to support prescribers to deprescribe. So of course that's about giving them knowledge. We also introduced a program theory about making sure that prescribers have the skills that they need so that they're appropriately equipped. And then here's one about their social professional role and identity. So making sure that prescribers feel that it is their responsibility to deprescribe opioids. So that gives you a flavour of what these look like. We did that for all of the domains. And we then tested them with the evidence to see which ones are supported by the evidence. And what we found, so we tested it with the trials, and we also tested it with that real world evidence. So we contacted service managers, commissioners to tell us about their services, deprescribing services. And it gave us 6 effective components for a deprescribing intervention to change prescriber behaviour. And we found that there were no trials and no studies already, no trials and no services that had all 6 components in place. So I'm going to very quickly run through these. just to give you a flavour what's in there. So the first one was about social professional role and identity. So prescribers do need to feel that this is a part of their role. They secondly do need to have the knowledge about how to taper, and that will be delivered through guidelines. They also need to have the skills to be able to initiate these tapering discussions, so there needs to be some sort of training. They then need to restructure the environment so that all members of the healthcare team are following the same approach. So any deprescribing that started doesn't get undone by someone else, so that patients aren't getting mixed messages. So that's why we need to restructure the environment to achieve that. We also need to address the potential for a negative social influence from patients, so patients being the barrier. So we need to make sure that patients have clear expectations of what that tapering process is going to be like. So it's education, not just about the opioids need to be stopped, but also what to expect from that tapering process. And then the final thing is having the right resources in place so that when that deprescribing pathway begins, that non-pharmacological measures are available, so psychological, physical support, those services are available for the prescriber and the patient to access. So that's a whistle-stop tour of the opioid toolkit. The website is here for you, and I think Kumud is also posting that in the chat so that you can go away and get some more details about its development and also the individual components. So at this point, I've just got a few questions that I'd like you to think about as we progress through the next talk. So think about, now that we've talked about behavioural science, what it looks like, what other medicines optimisation challenges might be suitable for applying behavioural science as a discipline, and then how you would like to take these forward and what sort of support the ARC might be able to give you to make this happen. So I will now hand over to Dr. Scott.
Debbie, can you see the slides okay still?
Yeah.
Great, thank you. So Debbie spent the last 10 minutes or so talking about deprescribing in the primary care setting and looking at a specific class of medicine, so opioids. So I'm now going to switch focus to the hospital setting, look at deprescribing more broadly across the board, but focusing on a specific group of patients. So this is deprescribing for patients admitted under the care of a geriatrician. And the research that I'm going to talk about today is research that started in 2016. And there was some preliminary work, which will be kind of most of what I'm talking about, that ran up until 2019, where we looked to develop an intervention to support deprescribing in hospital. We then submitted that to the NIHR, a UK government funder, and that's now been funded for us to take that work forward in the CHARMA programme grant. And I'll talk to you very briefly about CHARMA at the end. And I just want to say that this research, this initial research was funded by Pharmacy Research UK. So just a bit of background and context. So we know that roughly half of patients that are admitted to hospital under the care of a geriatrician will be prescribed at least one medicine with more risks than benefits. So these are medicines that would have absolutely been appropriate when they were first prescribed for the patient in their 40s, 50s or 60s. But over time, as Debbie alluded to earlier, that risk-benefit balance can shift unfavourably. And we know that these are associated with adverse outcomes. And so what we're looking for prescribers to do is work with patients, identify these medicines and proactively deprescribe them before that harm occurs. So that's kind of the gold standard, is stopping medicines before harm occurs. What we know, however, is that this is not necessarily widespread practice in hospitals. So we know that hospital practitioners are really good at identifying when medicines have caused a harm and then reactively deprescribing them. But there is quite a lot of scope to increase our proactive deprescribing, and that's really what we want to see. We also know that the vast majority of patients and their family members actually want deprescribing to happen in hospital, and they actually say to us that all healthcare encounters, doesn't matter which setting it is, which type of practitioner it should be, actually we want medicine stopped if they're not doing good for us anymore or if they're likely to harm us. So we know that there's a real missed opportunity here to deprescribe for these patients in hospital. So we embarked on a 3-year programme of work to really do 2 things. The first thing we wanted to do was to understand why geriatricians, as kind of the main targets for our behaviour, the people who are responsible for caring for these patients, and pharmacists as another group of practitioners who are likely to be involved in deprescribing, we wanted to understand why they weren't proactively deprescribing at the moment. So what were the things that were hindering them, and what things might help them to do that? And once we've done that, of course, as Debbie said earlier, we can then start to think about how we can put together strategies to address them. So the first thing that we did was we went out and we spoke to these people. So we ran focus groups across several NHS hospitals in England. And Debbie mentioned earlier the importance of context when you're thinking about implementation and you're thinking about changing behaviour. So we worked with large teaching hospitals and also smaller district general hospitals to see if we could tease out any contextual factors that might influence the way that we develop this intervention. Debbie introduced you to the theoretical domains framework earlier, and again we use the TDF in this study to, or as our theoretical lens, so that we can start to really understand how those barriers and enablers are influencing deprescribing behaviour. And our analysis for this study was really in 2 separate strands. So we initially undertook a fairly traditional qualitative analysis, so an inductive thematic analysis, where we're really listening to what people are saying, understanding that story, and unpicking those barriers and enablers. But we didn't go straight to the theoretical domains framework because we didn't want to miss anything that maybe didn't quite align with the TDF, but might be really essential to changing deprescribing behaviour. So we went in with a really open mind initially. Once we'd identified those, we then mapped them to the TDF. And as it happened in this study, everything did align quite nicely with the framework. Now, those of you who've undertaken this kind of work before, particularly qualitative work with the TDF, will probably know that what you end up getting is the vast majority of the TDF ends up being active in your data. So you're asking people for all these barriers and enablers, and they end up telling you lots of things, and you end up mapping to the vast majority, or if not all, of the TDF. Now that's great for understanding the problem. The thing is, you want to develop an efficient intervention, and you only really want to target the things that are absolutely essential for changing behaviour. And it's very likely that you don't need to target all of the TDF to change behaviour, but of course you've got to work out which bits of it are absolutely essential. And doing that inductive thematic analysis first is really helpful in prioritising the bits that you need to target, because they've given you that story, they've emphasised that certain things are absolute deal breakers, whereas other things are kind of nice things to have but not essential. So we then did a prioritisation exercise using our learning from the inductive thematic analysis. So what did we find? So starting with the thematic analysis, so we generated 4 themes from our data. So the first one, considerations of outcomes, is really all about geriatricians and pharmacists talking about the pros and cons of deprescribing. And geriatricians were overwhelmingly positive about deprescribing. They said, actually, you know what, there's way more benefits to deprescribing than there are risks, and we think we should absolutely go and do this. Pharmacists were positive, but they were also focused on some of the potential risks as well. And so some pharmacists would say, well, you know, if the medicine's not causing a problem right now, we might feel more comfortable leaving it alone than rocking the boat. So a bit of a barrier there already that we'd identified that we needed to address with pharmacists. Next theme was attitudes towards medicine. So this was geriatricians and pharmacists being worried about patients and their attitudes towards medicines and their attitudes towards deprescribing. And this was a bit of a misconception, actually. So there was kind of consensus across the focus groups that geriatricians and pharmacists felt that patients were generally resistant to deprescribing, that they weren't going to be open to it, particularly in hospital. And so there kind of wasn't any point starting those discussions. And we know this isn't the case. We know that deprescribing is acceptable to patients. We know that they don't want to be on medicines if they don't need to be on them. So the problem here isn't the patient. The problem is the misconception that these practitioners have, and that's something that we also need to address. The next theme is the role of different healthcare professionals. So this is the geriatricians and pharmacists now starting to carve out what their potential roles might be in deprescribing. And the pharmacists really felt that their role here was to support the geriatricians, so to spot opportunities for deprescribing and bring them to the geriatrician's attention, which really complemented actually what the geriatrician said and said, you know what, yeah, absolutely, we should be the ones to go and open those conversations with the patient, and then the pharmacist can support us with that as well. So actually we already had a nice idea of who would be doing what in this intervention. And the final theme was the inpatient environment. So this was participants talking about all the good things that are in the hospital that mean that it's a place that's conducive to deprescribing, so you can monitor patients closely. You've generally got them in front of you for a few days, so it's a good opportunity to deprescribe. But of course, there were some negatives as well. So the main one coming out of there was that the hospital setting is not always where the patient is most stable, and so is it always appropriate to deprescribe in the hospital setting? But overwhelmingly, in this theme, the consensus was that the hospital setting is absolutely a place that you can deprescribe and that you've got to manage those potential challenges. So that was the thematic analysis. When we then looked at how this aligned with the theoretical domains framework, you can see that the majority of the TDF was then active in the data in one way or another. So you can now see how we needed to prioritise from those 9 domains that were active in the data, which were the ones that were absolute deal breakers, and which were the ones that actually would be nice to have, but in the area of designing efficient interventions, which are the ones that we need to have essentially. And so we went back and looked at that thematic analysis. It became quite clear actually that there were 5 domains that were crucial to changing behaviour. So 4 barriers in red and 1 enabler there in green. So that then gave us a nice understanding of why practitioners struggle to deprescribe and what some of the potential solutions might be. So the next thing to do was to identify strategies to address these, and Debbie alluded to earlier that the theoretical domains framework is actually linked to interventions. So each domain is linked to several interventions, and these are often called behaviour change techniques. These are simply the active ingredients of interventions that are designed to change people's behaviour. Unfortunately for us, that work has already been done. So each of the domains is linked to several behaviour change techniques. On the screen in front of you are all of the behaviour change techniques that are linked to the domains that we identified in our data. And you can see actually there are a lot of them and they vary across the TDF domains. And actually some of these will be completely inappropriate for the behaviour that you're interested in. And that's kind of understandable because the TDF is a general framework. It wasn't designed for deprescribing, and actually it emerged from, in the early days, a field of research around physical activity, weight loss and smoking cessation. So actually some of these aren't going to be relevant to practitioners deprescribing. So for example, if you look at incentivising deprescribing, the first box in green, underneath that is reinforcement. The first behaviour change technique that is linked to that domain is threat. Now it's likely to be highly unacceptable for us to threaten practitioners to deprescribe. But actually we know that threat is a behaviour change technique that is really effective and acceptable in other situations. So for example, if you use your mobile phone when you're driving, you know there's a threat that you're going to get prosecuted, fined, you might even lose your license. So that's an effective behaviour change technique in that context, and actually from a public perspective highly acceptable. So what we had to do next was pick the behaviour change techniques that we wanted for the intervention. Of course, the best way to do that is to go back to your target audience, go back to the people whose behaviour is you're trying to change, and ask them to pick the behaviour change techniques that they feel are most acceptable, most likely to be effective, most likely to be feasible in terms of implementation. So that's exactly what we did. We went back to a panel of geriatricians and pharmacists and asked them to pick. And there are lots of ways that you can do this. And the one that the approach that we used was to convene an expert panel and run a nominal group technique workshop. So this is a highly structured consensus meeting, essentially, where people are asked to consider, debate, sometimes argue about things to pick, but eventually there's quite an amicable voting round. And in this study, the geriatricians and pharmacists coalesced around 6 behaviour change techniques to address our 4 barriers and 1 enabler to deprescribing. So that's where our initial work developing the intervention came to an end, and we submitted this to the NIHR so that we could take this work forward and then roll it out in hospitals to test the intervention. were fortunate that the grant was funded, and CHARMA, Comprehensive Geriatrician-Led Medication Review, started in September last year and is a 5-year programme of work. And there are 5 work packages in CHARMA. So work package 1 is around selecting outcomes for our definitive trial. So there isn't currently a core outcome set for hospital deprescribing trials. So the first thing we wanted to do was work out what we were actually going to measure the effectiveness of our intervention against, and that study has just finished. Thanks to anyone who participated in that study, and that's actually about to be submitted for publication. The second work package is really about taking that intervention forward. So where we ended up with was those 6 behaviour change techniques, quite nebulous high-level strategies, and that needed to be now packaged and formulated into something we could hand over to hospitals and say, right, go away and implement that so that we can evaluate its effectiveness. And that study was using co-design methodology, and that's just finished actually. So we're just finishing off the final touches of that intervention. After that, it's a feasibility study, and that's due to start in April 2022. So all things being well, we'll be testing the intervention's implementation and trial processes on a small scale. And then the following year, all things being well, we'll be running the definitive trial. And what's also quite nice about CHARMA is there is a cross-cutting work package with a team leading impact and dissemination, so that we're constantly thinking about how we disseminate our research and how we achieve impact. Now, if you want to know more about CHARMA, we'll post a link in the chat to the CHARMA website, and there are some screencasts on there that give you a little bit more information about the various work packages. And there's also a newsletter you can sign up for if you're interested in a bit more about CHARMA. So that's it for us for today. I'm going to hand now back over to Kumud, who I know is going to curate the Q&A session, but hopefully that's given you a nice overview of 2 quite different approaches to applying behavioural science to addressing medicine's optimisation challenges. So thank you very much.
Super, thanks, Sean. Kumud, may I hand over to you for facilitating the questions?
Yes, absolutely. So we've had a few questions and some comments come through as well. So thank you everyone for those. Firstly, I just want to remind everyone that the recording of the session will be made available within the next few weeks on the ARC website. I know someone's posted a question about the slides, but the recording will have the slides in them. So you'll be able to access the slides through the recording when it becomes available. So the first question I have is from Lisa Stevenson, and this is a question for Debbie. So her question is, how do you influence overworked practice staff who don't have enough time to do medication reviews effectively, which would include deprescribing of inappropriate medicines?
Yeah, so this is a theme that constantly came up when we were looking at the real world innovations. And so this is related to restructuring the environment and thinking about the resources that we've got. So we're working through implementing the toolkit actually locally and within the Eastern region. And we're looking at the moment to map what resources we've got and decide the threshold at which we might refer, for example. So a certain area where they might have lots of capacity potentially for referrals, for psychological support, might have set quite a low threshold for prescribers to refer and say, actually, you don't need to have these consultations with patients, just refer them on. Whilst another organisation may actually not have access to those resources, and therefore the prescribers will need to agree at a much higher threshold and caseload that they will manage, and therefore only use the resources as and when required. So in terms of answering your question about what do you do when if people are really time poor, we have to set. So you work together and you set thresholds that are achievable within the organisation. And it may be, so if it really isn't achievable, if there are other priorities in the organisation that are more important than the deprescribing, then don't set it as a priority. So whatever is genuinely are the priorities, those are the things that you need to work within the existing resources. Does that answer the question? Do you want to move on to the next one, Kumar?
Yep. Well, yes. Yes, she's replied actually.
Oh,
thank you, Lisa.
Thanks, Lisa.
So the next question is from Suzanne Drury, and her question is, are you able to test whether introduction of pharmacogenomic testing would influence deprescribing behavior where relevant?
So pharmacogenomics testing, so are we thinking about, so that's the, so if the prescriber and the patient know that on balance the chance of harm outweigh the chance of benefit. So I think if I've understood correctly, then that would mean that that's one aspect of the determinants that influence behaviour that has been addressed. So if we look at the toolkit, one of them is that, you know, this is something that is really important, and therefore they know that on balance the benefits outweigh the harms of stopping the medicine. But there are lots of other things that we know need to happen in order for someone to deprescribe. So even though they can say, yes, this is really important, we don't know that they're necessarily still going to undertake the behaviour. What it might do is actually reduce the amount of inappropriate prescribing in the first place, for example. I suspect that might be where it really has its benefit.
Thank you, Debbie. I'm going to switch over now for a question for Sean. I think this is a quick one for you, Sean. So Andrew Smith wants to know what percentage of pharmacists were interviewed. Sorry, what percent of pharmacists that were interviewed were actually prescribers?
Oh, good question. And off the top of my head, it was roughly half. So this was a couple of years ago. So for those outside of the UK, we've had a real exponential increase in pharmacists trading as prescribers in the last couple of years. So these focus groups were in 2018. So it was about 50%, which for the hospitals that we looked at was probably about right. Now I recognise actually that would be much, much higher. Even in those hospitals. So at the time, about 50%, which was representative of those trusts, but now that could be very different. What we did specifically, though, explore was, because we wanted a mixed bag so that we could see whether having prescribing rights changed things, and actually it didn't. So the pharmacists kind of said, you know, this is our role. Our role is a supportive role, and even the prescribers would say that is still the role that they want to assume in this process. That it still has to be the geriatrician that is actually physically crossing the medicine off the chart and having that conversation with the patient. But there were clearly some pockets. There was clearly having the qualifications clearly is an enabler. You do have, you know, you've developed knowledge and skills in the area, so it helped, but it didn't change the role that pharmacists wanted to have in the process. Hopefully that answers the question.
Thank you, Sean. So this is a question that has just come through from Reema Chauhan, and it's for both Sean and Debbie. And her question is, one of the challenges our clinicians always highlight as a barrier to deprescribing is that medication has been initiated by a specialist or another clinician. So there's reluctance to deprescribe. Is there something that you found in your focus groups on how you could manage this?
So from the opioids perspective, it was less of an issue of this having been initiated by someone else. It does, however, get picked up by the element in the toolkit that refers to this consistent approach, so that deprescribe, you know, the initiation of tapering doesn't get undone by someone else. So that's where it got picked up. However, Sean, I think, will have a little more comment in terms of the influence.
Yeah, so this is something that consistently comes up in kind of focus groups and interviews and lots of systematic reviews that show this. So from our study, actually, I think geriatricians are somewhat impervious to this barrier. They're kind of quite happy to say, no, we're looking after the patient at the moment. You know, if we don't think it's appropriate, we will stop it, and that's that. But absolutely, there are other specialities and other professional groups that is a real barrier for them, and we are doing some separate work in care homes at the moment looking at deprescribing polypharmacy, and that is a huge problem that we're trying to an element of that intervention is trying to address that barrier. So yeah, watch this space to see what we design for that.
Great, thank you, Sean. So I just want to comment on some of the resources that people have been putting in the chat. Thank you very much, Karen Cannons, she's put two resources in the chat. It looks like they related to opioid and pain management and deprescribing around that. And also we had a comment early on from Anne Bentley from Lancashire, and she says that East Lancashire have just won an award for a multi-agency teamwork to develop opioid reduction pathways and clinician training that was delivered great reductions. And she commented on Debbie's opioid toolkit, where she says a slide that showed the 6 strategies nicely described the approach that they're using in East Lancashire. They also involved patients in developing their pathways, and she commented that you also need benchmarking and comparative and trend graphs to provide positive reinforcement to clinicians. So Debbie, I see you nodding your head. Do you want to comment further on?
Yeah, so they fit in with some of those elements of the toolkit. So the first step, which is making sure the prescribers are very clear that this is a part of their role, and one of the or several of the ways that have been used are benchmarking, because the organization, the employing organization, is monitoring them, comparing their performance, things like incentivizing. All of these things feed into communicating the message to prescribers: this is your role, you are expected to do it.
Great, thank you. So there's a question that's come through from Daniel. I'm not sure how to pronounce his surname, Okewo. So great presentation. So thank you very much, Daniel, for that comment. He was wondering if you were aware of any patient education resources currently available in the UK for deprescribing.
So there are a wide range of resources out there, and we can post the web page for I've forgotten what it's called now, the pain. We can put that up as a resource later. I think one of the things that was missing in most of the trials and the innovations that we saw was that what to expect from the tapering experience. And I think this aligns with the comments from one person about making sure you've got shared decision making, you take the patient along with you. So there are lots of resources about why it's important to stop opioids, all the bad things that can happen. But patients, quite rightly, are very nervous about the negative consequences as a result of stopping the opioids. So being really clear about what that experience will be like enables patients to go to work with the prescriber during that tapering process, and addresses that negative social influence that patients could have of actually being a barrier to deprescribing. So I think there is a small gap in the literature in terms of giving in terms of patient-friendly information about what to expect from the tapering experience.
Great, thank you. That ties in quite nicely with a comment from Stuart, who said that the main fear for most patients that he speaks to is that the pain will worsen when reducing medication, and quite often low and slow approach works well initially and then can be patient-led. So I've actually got another question as well from Stuart. So his question is, what are your opinions on the current NICE guidelines for chronic pain for the non-use of opioids for chronic pain, which promote the need for deprescribing?
What was the latter part? What are my views on them?
Yeah, opinions on the current NICE guidance.
So the NICE guidelines, I guess, are that they are giving us all the right messages. What we now need are the tools to then deliver on them, and so that's where the opioid toolkit comes into play. So it aligns with the messages that are in the NICE guidelines. So it describes how we need to think about using non-pharmacological options, but we recognise that free access to oodles of non-pharmacological options is just not currently achievable. So there is still a need for for opioids potentially for short periods of time, and then working with patients to see then what else is out there, because we just don't have the resources to deliver it as per NICE guidance at the moment.
Great, thank you, Debbie. There's another question from Sejal Ladd. She says, how do you deal with care home patients who may not have capacity, and therefore you have to rely on what the carer is telling you, and therefore patient is not involved?
Sorry, Camille, what was that?
So this is a question around where the actual patient is not involved in any of the decisions, but the carers are involved. So a question from Sejal is, how do you deal with care home patients who don't have capacity themselves to engage in the discussions about deprescribing? I guess that's her question.
So the partner with whom we have that discussion, I guess, doesn't make much difference who that partner is. The process is the same. So there will be the same barriers, the same enablers to deprescribing, and what we all actually, something we haven't really touched on is with behavioural science, we always need to ask ourselves, what is the behaviour? What is it that we're asking the prescriber to do? So if we are asking the prescriber to have a consultation with a member of the family, then there may be additional barriers that are in place that may not have been in place for a consultation with the patient that is what is freely accessible at any time. So there could be some factors in terms of getting access to the patient. But I think otherwise there are no real behavioural factors to influence it. Sean, have you got any comment?
I completely agree with what you're going to say, and I think sometimes we as practitioners can be really quite worried when the patient doesn't have capacity, and that can be almost a reason for not doing it. But I guess I would say that the patient not having capacity should not be a barrier to optimizing the medicines that they're taking. And so, we should be deprescribing. And as Debbie said, it might be with the family, it might be with the care home staff and the general practitioner, whoever is able to contribute to that discussion. Yeah, as Debbie said.
Great, thank you, Sean and Debbie. So I just want to thank people that have been posting resources on here. So we've got a resource from Lisa and another one from Liz. So thank you very much both for adding. Can I just say
also thank you, Anne. It's the Opioids Aware website was the name that was eluding me. So and Anne's posted that. So that's a really good UK-based resource for guidance for patients and prescribers.
Thank you. There's quite a few coming in quite swiftly. I'm just going to try and read through them. Some comments coming through. So one comment from Sadna Murphy is, I think deprescribing should be discussed at the point of starting prescribing. Do you want to comment on that, Sean and Debbie?
Well, Debbie kind of introduced this at the very start of the talk, that it's not a new thing, deprescribing. It's part of good prescribing, isn't it? I think the reason it's emerged as its own field, its own quite trendy field of research and practice, is that it's actually really difficult. And whilst it's part of the same process, it is a different behaviour to prescribing. We know that's true. The barriers and enablers to prescribing are very different to the barriers and enablers to deprescribing. And I think one of the things that comes up consistently when we talk to practitioners is not only is deprescribing not discussed at initial prescribing, actually the opposite happens, and patients are historically told, this is going to be for life. Don't ever stop taking it. And that's then really difficult for the practitioner coming along 10, 20 years later and says, oh, the risks and benefits have changed. They're saying, well, hang on, prescriber A told me this, I was never to stop taking this. And that's really difficult. I think that's changing, but I do wonder whether there's more we can do to make that initial prescribing more conducive to later deprescribing. Debbie, have you got anything to add?
No, that was a really good summary.
And thank you all for your comments that you've put through as well around the topic area. So one of the questions that Debbie
I like the
posed,
comment, yeah, the tabloids are very effective at deprescribing the statins.
Absolutely. So one of the questions that Debbie posed as part of the presentation was what other medicines optimization challenges might need behavioral science? And Liz Courtville has put in the chat antimicrobial stewardship. I don't see any other comments, but
And the only other
antimicrobial.
one that I spotted was patient-led decision making.
Yeah, so that one as well. The patient-led decision-making and antimicrobial stewardship. And of course, we've got our webinar, and the second webinar in the new year on medicines adherence as well. So that's another area where behavioral science can be quite useful in trying to address the medicines optimization challenges.
So I think in the field of antimicrobial stewardship, I think there is some work in that area already. So we could dig out some of those resources and make those available.
Yeah. Comment had come through biologics and biosimilar prescribing. Yes, absolutely. Thank you, Denise.
I was about to say, Denise, oh, there is some work in this area, I believe, and it was you, Denise, that was doing the work in the area.
Great. So I don't see any other questions that we haven't addressed that have been posted in the chat. So Debbie, I guess it's a right time for me to hand over to you now so that you can do the roundup.
Lovely, thanks, Kumud. This has been a really useful exercise for me, actually, to get a feel for what's going on out there and your thoughts on both the trauma intervention and the opioid toolkit. So these are contact details for myself and for Sean, and we'd be delighted if you have any thoughts about projects you want to take forward, get in contact with us. We've also sought consent to share details from those that are registered. So if you've done that, thank you, and we can then link people up with common interests. The other thing that Sean and I are thinking about doing is actually building some training materials to help practitioners and clinicians to apply behavioural science to design and then implement new ways of working. So that will be coming at some point soon, and hopefully that will be useful to you. But otherwise, there's nothing else from me. Was there anything, Claire, that you wanted to add?
No, I just think what an engaged group, and you sort of almost feel there's if we could take the collaboration further, that would be good. Sorry, I got a phone call in the middle. Sean, did you answer the question about what would you do differently given the time scale? Because I thought it was an interesting conversation, how long it takes us to get to this place.
I did see that one. No, I didn't. So long story short, actually, the 3 years, there was lots of other things going on as well. So actually to do the bit that I presented today was probably 12-18-month project. And that was me doing it full time. So I think that's probably about right. But obviously I went into this, there wasn't much literature at the time on the barriers and enablers in hospital, whereas there's lots more out there now. So there's potential for efficiencies there now that the field has grown, etc. So I think, yeah, go and do it if you want to do it. I mean,
just to underline, one of the keys in this kind of collaboration is to accelerate our learning. And I think the people who've joined have absolutely done that with examples from different parts of not just UK, but also abroad. So thank you for contributing in that way too. Thank you.
So thank you very much. And we will be running the next in this series of seminars early next year. So I look forward to seeing you all then. Thank you. Bye.